Krupa.
So good morning and welcome all of you as we start our weekly clinical meeting. Our first presentation is by Medicine Unit 1 by Dr. Krupa. The title is Hit and Run.
Good morning, everyone. I'm presenting on behalf of Medicine 1. Mrs. A, 48-year-old female, was brought in with complaints of a road traffic accident 4 weeks ago, followed by fever for 3 weeks and impaired cognition for the past 3 weeks. The history of present illnesses: she met with an accident on 3rd Feb while riding a two-wheeler, and she sustained severe head injury with occipital fracture, SDH in the frontal and occipital region. She was transferred from a local government hospital to a tertiary care center for further evaluation. And 7 days post-admission, she was discharged as her hemorrhage had subsided and the patient was improving clinically. Post-discharge, there was a gradual deterioration noted in her sensorium along with fever. She started to have decreased response to verbal output, self-care. She was readmitted in a tertiary care center for evaluation of the same. So the symptom complex that we are looking is post-traumatic. There is an interval post that there is a decreased cognitive function. There's an impaired sensorium. On examination, patient was conscious, oriented to person, not oriented to time and place, is obedient to commands, E4, M3, B3, M5. There's generalized rash present. There's no ishkar. There is no neck stiffness. Pallor is present. Higher mental function, patient is conscious, oriented to person. The speech is slow, answers questions appropriately only at times. There's no slurring. And there's generalized decreased verbal output. Cranial nerves, bilateral light reflex is normal. Bilateral pupillary reflexes are normal. Accommodation reflex could not be assessed. No ptosis or nystagmus. There's no deviation of mouth or drooping of saliva or loss of nasolabial fold. There's a weak gag that was present. No deviation of tip of tongue. Rest of the cranial nerves could not be assessed. Motor system is also grossly normal. Sensory system could not be assessed. Cerebellar system, there was no swaying when attempting to sit. There's no nystagmus or slurring of speech. Gait could not be assessed. Any differentials that you could think of?
Yeah, please.
Go ahead.
Go ahead.
So the differentials that we were considering at that time was a cerebral abscess, cortical vein thrombosis, a partially treated meningitis or a meningoencephalitis, and the SDH that was prior present that has turned into an abscess. On investigating, there was anemia. Rest of the routine CBC was normal. LFT showed an increase in SGOT, PT, and ALP. Creatinine was normal. Electrolytes was also grossly normal. CSF glucose showed 72 gram protein with 24 cells, predominantly lymphocytes. An MRI brain with contrast was done, which showed a subacute dural venous sinus thrombosis involving left transverse and sigmoid sinus and proximal IJV. We're looking at an entity called post-traumatic cortical vein thrombosis. These are a couple of articles that have been published. There's no major research that has been done actually on this. When we look at head injury and RTAs, we primarily look at hematomas, bleeds that happen, and fractures that are there. But there's a small entity called cortical vein thrombosis that can occur in those cases, which should not be missed. So the mechanism of the thrombosis, there is an obstruction to the dural sinus, which increases the venous pressure. Two things that happen is impairment to the CSF absorption that causes the increased ICT. There is venular and capillary pressure increase that causes decreased capillary perfusion, decreased cerebral flow, and there is a cytotoxic edema. Along with it, because of the increased pressure, there is venous and capillary rupture that happens, causing parenchymal hemorrhage, and the blood-brain barrier is disrupted, again causing a vasogenic edema. So these are the major cerebral veins and sinuses. So we have the superior sagittal sinus, inferior, and the great vein of Galen, and that's draining into the straight sinus. Then there's a transverse sinus from cavernous sinus drains here. That is followed by the sigmoid sinus, and finally the internal jugular vein. The risk factors primarily for there are transient risk factors, there are permanent risk factors. Transient risk factors being pregnancy and purpurium, dehydration. Mechanically precipitants are head injury, post lumbar puncture, post neurosurgical procedures, post jugular catheterization. The drugs that can cause is oral contraceptives, hormone replacement therapy, androgen, asparginase, tamoxifen, glucocorticoids. Even cyclosporin is a very known drug causing cortical vein thrombosis. Inflammatory conditions like SLE, Behçet's, certain malignancies, especially hematological malignancies. Other conditions are prothrombotic stage like protein CS deficiency, factor V laden mutation. The whole lot of prothrombotic conditions can cause polycythemia and severe anemia, including PNH. CNS disorders like dural fistulas, and other disorders like congenital heart disease and thyroid disease. The clinical features are basically clubbed as features due to isolated intracranial hypertension. So that presents with headache, with or without vomiting, papilledema, and visual problems. Focal syndromes like focal deficit seizures, encephalopathy due to the edema that's there, multifocal signs, mental changes, status changes, and the stupor or coma. Specifically to the vein, the deep vein that is thrombosed, you can have features that are specific to that. For example, lateral sinus thrombosis can cause cranial nerve palsies. Cavernous sinus thrombosis can cause deep orbital pain with oculomotor palsy. Jugular vein thrombosis can cause a pulsatile tinnitus. So some imaging that needs to be seen. This is actually the dense delta sign. This is a CT brain non-contrast will show a dense delta sign in the superior sagittal thrombosis cases. When you put a contrast, what happens is the thrombus, there's no uptake over there. So there is a halo that is formed. So that's called the empty delta sign that's there. This is again without contrast, the thick cord sign showing the thrombus. This is an MRI with contrast showing deficits where the contrast uptake is not there due to the thrombus that is formed. The other test that can be done is a D-dimer, and D-dimer is not very specific, but it can be done. LP to rule out a meningitis and evaluation for a prothrombotic state. Primarily, the treatment is reversal of the cause of the thrombus. Symptomatic management of raised ICT can be managed with anti-edema measures, and seizures can be managed with anti-epileptics. The primary treatment is anticoagulation. Initially, low molecular weight heparin is used. Unfractioned heparin is used in certain cases, especially post-chemotherapy malignancies that are causing the thrombus. But low molecular weight heparin is the initial treatment of choice. Long-term treatment can be warfarin or direct oral anticoagulants. The duration of anticoagulation depends. If it's a provoked thrombus, like in our case, the RTA, the trauma that was the provoking this, in a provoked thrombus, 3 to 6 months of anticoagulation is sufficient. In an unprovoked, it's around 6 to 12 months. But in case of a recurrent thrombus that is being formed, or there is a permanent prothrombotic state that is there, a lifelong anticoagulation is also recommended.
Okay, thank you. Any questions? Any questions? I think it's empty. Where was the SDH and which was the veins that was thrombus?
Both side was actually the right sided SDH, and the right sided sagittal vein thrombosis that was there.
It was on the same side. Okay. There was any fever, you said?
Yeah, there was a fever. Actually, I've only presented one aspect of the patient came with a lot of other. Patient also had a phenytoin-induced rest syndrome that was concurrently that was there. So the fever was actually attributed to that. So once the phenytoin was withdrawn, the fever subsided.
Okay. But these were 4 weeks back was the history of
RTA.
And the history of presentation was how many?
To us was around 2 weeks post this. Patient was admitted at JIFFERENT and she was evaluated there prior.
If there are no other questions, then we'll go to the next case. Our next one is from Medicine Unit 2 by Joseph. The title is Crummy